p.m. on Monday. She will not meet today. Let's see.
From her recording, it didn't sound like we were meeting next week either. It was going to be a recorded.
Okay.
But I could be wrong.
I'm just texting her back here real quick about Zoom recordings. Did she record it on Zoom? Has anybody gone in to see that it worked?
Yeah, she sent us a down. We had to download it.
Okay.
Yeah, it worked.
Okay. So you will not meet today. It will be on Monday. You guys have her email if you need to get a hold of her. I believe that's the T-Pain one that she likes to use.
Yes, I have it at least.
Okay, let me just give it to you here just in case. You might have had it from EKG, but let me just grab it again.
That's the email she used to send out the announcement yesterday, so we should all have it.
Okay, yeah, so it's tpain31775@gmail.com. So if you have questions, I would certainly use that as a primary contact thing for her.
I'm hoping she'll get back to me because my email is wrong. I did send her an email last night.
Okay. Yeah, I know she's working today for sure, because that's where she's texting me from. Okay, so as you've noticed, this lecture, let me bring back my Panopto here, sorry. Okay.
And then Scott, I had a question about the portfolio that you just mentioned for this class. When I was going through the syllabus and everything, where is that stated? Because I couldn't find any information on it or percentage or how much it's going to be worth.
Okay, say that again, sorry.
The portfolio that you said we're going to be graded on for this class, is it in the syllabus or where did you, because I didn't see any information on that.
Let me see. I've got it on the grades, where you go to the grading. It should show us what value it is. It's not in the syllabus. That was something I just started doing like a year ago. So they should be, let's see, so that is the quizzes.
It doesn't show it on my grades, like when I go through and look at where the grades are and everything. It has all the quizzes, the midterm, the final.
Yeah, I believe it's, so the one section is quizzes, the other section is going to be each of those sections. So I believe it's 10 points each. Let me go to my.
Is that the assignments?
Do you guys get the assignments tab?
Yeah, I see assignments that are 10 points each.
Oh, I guess I
is that portfolio
duplicated from the
yes.
quiz. Okay.
And that's what it's going to be. So there's a quiz section and then there's an assignment section. The assignment section is those portfolio items.
Oh, okay. I thought it was just duplicating because sometimes it'll duplicate like when it's weighted versus unweighted, blah, blah, blah. So, okay.
Yeah, it gets to make more sense once we start seeing grades enter in. So, okay.
Scott, on the study guide for contrast, it says know the types of contrast used and where they would be useful.
Yes.
So on the types of contrast, are you referring to brand names like Definity and Leviovist, or are you referring to where the book talks about, I can't even pronounce them. I mean, the one I can pronounce is the saline, and the other ones are they talk about lipid membrane and saccharides. And are you talking about that or brand names?
So yeah, as you're filling out a study guide, I'm saying yes to both. So what I want you to do is to know the agitated saline versus the LVO, which is left ventricular opacification. That's a type of contrast. That is typically those brand names. But knowing the brand names is also helpful. In particular, knowing Definity is probably the most commonly used in the US. Also, Lumason is come onto the market in the last few years. It's been a strong competitor to Definity. Both of those types, as
You
well
said
as Opticon and others, they're very, very tiny. They pass through the lungs. They don't rupture in the lungs like the saline contrast do.
You said LVO versus what was that again?
So LVO versus agitated saline. So agitated saline is us taking in a syringe a certain amount of saline solution, just like out of an IV bag type saline solution. And you take 2 syringes and you mix them together with some air, and we're creating bubbles basically with that, and then we inject it into the person. I know that sounds sketchy, since every crime show shows somebody that's injected with an air embolus and the patient dies. Yeah, so it sounds a little sketchy, but we do it. Just make sure it's agitated. So the agitated saline, we'll talk about this in just a minute. I am going to go over some of these, just showing the differences and what we expect. But yes, know why we would use the agitated saline versus the left ventricular opacification. Or if we're talking about perfusion imaging, if we're looking at the muscle, I know that we've commented on that briefly in the past, using contrast to go into the muscle tissue itself and look for absences of filling, like in CAD might occur. So let me first point you to, let me share my screen here. I'm going to first point you to the Canvas announcement.
Yeah, that's a cool video.
So yeah, if you haven't watched the video, that's fine. You don't have to watch it already. But under announcements, you definitely want to go to this. So I'm going to jump into here. It's just thinking. So there's a couple videos here. The reason I don't have a PowerPoint for this is because in the past, I've actually had people from like Definity and that come give guest presentations to the students. And I think that could be quite nice. COVID and all makes it a little tough. But I think it's just kind of helpful to know. So go down to so there's a few announcements that are out there. If you haven't seen those announcements, definitely look through the announcements. But I'm going to click on the echo enhancing agents / contrast. The reason I label it that way is because in the industry, when we talk to a patient about contrast, what do you think a patient thinks about? What do you think their experience has been with contrast in the past?
Iodine.
Yep, iodine, nephrotoxic, meaning that it's toxic to the kidneys, and that can be quite concerning for patients. So to avoid scaring our patients, we like to call them echo enhancing agents. They're very strong reflectors as these bubbles go in, and they give us a really good interface on our ultrasound. It gives us a contrast, but we don't like to call it contrast in front of patients because of that. So I definitely want to point you to those 2 videos. They are, they're videos basically one is from the ASE. That's the bottom one. The top one is, I believe, from Definity. So they're one of the manufacturers of contrast. And so they give you a really good overview of what contrast is, how it's beneficial to those. So I'm going to really, instead of a PowerPoint for this, I'm going to point you to that. Yeah,
that second one is a PDF, not a video.
Oh, sorry. Yeah, PDF. Yes, you're right.
Did you mean it to be a video?
No, it is a PDF. So that's the ASE's guidelines on that.
Yeah, and I didn't see any questions or online quiz for that.
No, there shouldn't be. Well, there should be for contrast. For our quiz, you mean on Thursday?
No, you posted that there was an online quiz after each of them in your announcement.
That will be, the online quiz will be our quiz on Thursday. Does that make sense? Okay. So the ASE document is, it's 14 pages, but it basically tells you all the details about contrast. I'm going to go over a few take-home messages today that I want you to be aware of for sure, but watch the video that they have from the rep and look at the ASE document. And then you do want to kind of at least peruse through the chapter, but I'm going to kind of go over the main points today anyway, because again, it's not meant to be super intense on this chapter. I just want you to have a good understanding of what's the point of using contrast. Okay. And again, when I say contrast, I am going to be intermixing and probably instead using the name echo enhancing agents. Okay, so just be aware of that. So let me just bring something up for me to look at while we go through this. I just want to hit some main points here to start with. And that is, so what do you think a contrast is made of? So it is a contrast, giving us contrast from our ultrasound to be able to distinguish one thing versus another. That's the point of it. Typically, when we use contrast, as we discussed in physics, we want to have a low mechanical index. In fact, an ultra low mechanical index would be ideal, because if the mechanical index is too high, the bubbles tend to rupture. So as the bubbles stretch, they get very tense, and the more tension there is on the surface, the more likely they are to rupture. And as they contract and stuff, they expand and contract, expand and contract. If they pass that threshold, they're likely to burst. We want the bubbles to not burst. We want them to typically stay there longer so that we can see the differentiation between the blood area and the tissue. Also, when we drop our mechanical index and we have a very low power output, the appearance of gain on the walls, it becomes very, very dark on the walls. But we have to have it that way because these are very, very strong reflectors, and it's a super intense signal when we get it. So what do you think a contrast is made up of? The bubbles themselves, what is it? Any guesses?
Saline.
Okay, so if we use saline, yes, it's going to be saline, and then the air, just regular air, is the internal. What do you think on the bubbles of a drug manufacturer's type like Definity or Lumason? Does it use regular air?
Is it a gas?
Okay, there is a gas, and so it's an inert gas, meaning that it doesn't interact with other things. It's not reactive. You guys have all heard about when people take like free radicals, or they have free radicals in their body, and they take, like grapeseed extract or something to help, reduce your free radicals, right? So what happens is a lot of things that we take into our body tend to interact with other things. The perflutrin gas that is used, at least in one of the types of contrast, I think that's found on page 40 of the text. So perflutrin gas is an inert gas, meaning again that it doesn't interact with your tissues negatively. It does not react with our cellular level. Okay, that's important. So we have an inert gas and we have a shell. Now in a saline contrast, we're simply using saline that creates bubbles. So if you were to blow a straw into a bag of saline, you would get bubbles sort of like you do in a milkshake, okay? Those create bigger bubbles. Those bubbles for agitated saline, they rupture when they get to the lungs. So they go into the vein, we inject them into the vein, and they go through the right heart and they go to the lungs, and then those bubbles burst. Okay, they do not go through to the left heart at all. They should not go through to the left heart at all. If they do, that's a clue that there's a shunt. Okay, so we use agitated saline to help us to define and see shunting. Okay, so we're looking for holes in the heart like ASDs, VSDs, PFOs, those sorts of things. And so we inject it into the right heart. None of it's supposed to go across. If it does go across, that tells us that there's a hole somewhere. That hole could be in the atria. That hole could be in the ventricles, in between the ventricles and the interventricular septum. It can be in the lungs through an arteriovenous malformation. So those sorts of things cause a crossover from the right heart to the left heart. And if that happens, we've proven that there's a hole somewhere. And the concern with that is that if somebody's likely to blood clot, like we talked about in venous, that it can go across the heart and end up causing a stroke. Okay, so we want to look for those types of things, and that's why we use agitated saline. So we'll use that when we have a concern about a hole between the interatrial septum or the interventricular septum or somewhere else. So that is the agitated saline. Back to the LVO, the left ventricular opacification type of contrast, which is like Definity, Lumason, those types of things. So we have our perflutrin gas or other types of inert gases. That gas when it does rupture, because all the bubbles eventually rupture, that gas is dissipated and breathed out the lungs. And that's how it's gotten rid of from the body. Okay, it does not interact with my cells, but it does get breathed out naturally through the breathing process. Now, the bubble shell is created by a lipid layer. Okay, so sort of like your cells have a lipid layer, that lipid layer is able to be very, very tiny. So these are much tinier than the agitated saline ones. So they do freely pass through the arterial capillaries of the lungs. And so they're able to go both in the left heart and the right heart. And they're so tiny that they can go into the coronary arteries and they can perfuse the muscle tissue and so forth. So I've already thrown out a couple of terms. One is LVO, so left ventricular opacification. If you understand what opacify is, it means basically to make white or to kind of not transparent, so to speak. And so our idea with LVO is to highlight the blood pool inside the ventricle so that we can define that and contrast that with the walls of the muscle. And again, because we drop your power setting so low, you have a good contrast between the wall and the blood pool. And so we can define very, very well where the endocardial layer is. Okay. So that's good for looking for regional wall motion segments. It's also good for defining if there's a thrombus that might be floating out into the fluid and we can't quite see it with regular 2D. It's good for defining masses and tumors. Okay. So those are all areas that we might use that contrast. And as you go through the video, they'll show you examples of those where you can see that you thought you had it, you thought you knew what you're looking at, and then you use the contrast agent or the echo enhancing agent, and you saw that it very well defined what the pathology situation was. Okay, so that's an LVO type of contrast. Nancy, go ahead.
You need that, the tiny bubbles to go through to the left side of the heart to see those things, and that's what LVO is?
Yeah, so LVO is just left ventricular opacification, so meaning that we're lighting up the blood pool of the left ventricle. That's what LVO is. We also can use that same type of contrast for perfusion, meaning that that now goes into the muscle tissue and we can see if there's an absence of filling inside the muscle tissue, which can be useful for looking for coronary artery disease specifically. We use different settings and stuff for that, and we're going to use your physics a little bit different. We're going to really optimize over those wall segments individually. And with that type of scanning, we also have a button typically on the ultrasound system that you can cavitate the bubbles all in one shot. It gives a high power flash that basically ruptures all the bubbles and starts a timer, and then you can see when that fills or doesn't fill so that you can define that better. So it's a little bit different application of the same Definity or Lumason or whatever it is we're using. Yeah, go ahead.
Is that what they did in that video when they said flash and then it was just prior to the flash and after the flash, and that was what the flash is, the cavitation? Yes,
that's exactly right. Yes. Oh, and by the way, I want to give a shout out to those that have taken the registry for the SPI already. So I think 7 people to my knowledge have passed it. So kudos, good job. And more to come, I know. That's awesome. Okay, so that's kind of what the LVO is versus the perfusion versus the agitated saline. So kind of knowing what those are, just to throw a few brands out there. First of all, yeah, go ahead, Kelsey.
So replenishment, was that along the lines of the perfusion thing?
Yes, it is. So when we rupture the bubbles, we want to see how long it takes to fill in certain areas. The reason we do that is because if you just fill it in and you're just letting the bubbles randomly go through, it might not be quite as clear. Another place outside of the heart that they use that is looking for tumors and masses like in the kidneys or liver. They'll actually press that button, cavitate all the bubbles, and then they put the timer on because the tumors and masses typically draw in blood flow. They're very aggressive and they fill very quickly as compared to the regular tissue around it. So that's another application where they might use it clinically.
Oh,
And we're doing that with high pulses
Yeah, high power.
or high
pulses.
mechanical indexes.
Yes, exactly. So they'll flash it out, they'll burst them all, and then they put a timer on to see what they do, because it's found that tumors that are very aggressive tumors that are typically infiltrative type of tumors, they create their own significant blood supply that dominates the regular blood supply. That's just a characteristic of tumors. So that can be helpful in that respect. But in the heart, we'll do that to see, looking for absence of filling areas in the muscle tissue to see that it's, which would indicate there's a blocked coronary artery somewhere. Okay, so again, take home message, these are very, very, very strong reflectors. Okay, so they interact very strongly with our ultrasound. We need a low mechanical index, not only to prevent the rupturing of the bubbles, but we also need it to not be so overwhelming to our image, because it's going to look like you super gained it out because of just the intensity of it. Now, taking that into consideration, if I additionally put a pulsed wave or a continuous wave Doppler through that, it's going to intensify significantly our Doppler waveforms. Contrast can be used for Doppler. I think it's quite appropriately used for Doppler. And then just knowing the difference of where you would use it. So things like Definity or Lumison or Optison or Levovist are different brand names of different types of product. Those are the tiny, tiny, tiny bubbles that pass through the lungs and go into the left heart as well. And they're used for looking at wall to blood pool differentiation, as well as perfusion. Saline, the agitated saline, or the big bubbles, they rupture in the lungs when they get to the lungs, and it's supposed to only be in the right heart. We use that one specifically for looking for shunting. The other ones aren't helpful to see shunting because it's going both in left and right heart anyway, and we won't be able to differentiate those. Okay, so if you're looking for shunts, you're doing agitated saline. So I mentioned earlier that when we think back to movies and stuff, where somebody's going to kill somebody and secretly and all that, we inject a bubble into somebody's arm or something and they die, right? So is there a legitimate concern about safety with these products? Okay. Again, the FDA would not allow us to use them if it was a significant safety hazard. So take that as a take-home message, is that they are relatively safe products to use. Is there risk? Yes, potentially there's always risk with these types of things. Anytime you inject something into the body that doesn't belong there, there's a safety risk to it potentially. Yeah, Nancy?
Do we inject them in different locations? Where do we inject it?
You will typically inject it into the right arm veins. And we do that because typically your patient's on the left side, so it's just easier to access the right arm. But they do go into veins, not into arteries. Good. And it takes a few seconds to get through from that vein when you inject it to get to the heart, and then it has to cycle through. And then if we're doing the LVO type of perfusion, or the LVO type of contrast, it's going to take a little bit to get through the entire body to get back into the left heart as well. So you're going to see the right heart fill up right away, and then it's going to take several seconds, and then you'll start to see it in the left heart also.
So when it goes through the lungs and in the capillaries, how long does it, when we're supposed to breathe it out, but then it comes back into the left heart?
Right. So good question. So the agitated saline, so they break in the lungs and they get breathed out and all that stuff. The other ones go through the body, they circulate, but they have a very short half-life. So they tend to rupture over a few minutes. Okay. So it's not going to be an immediate thing. So if we do a contrast for stress echo, for example, we'll do contrast at rest, and then we have to inject more contrast before we do the stress echo portion of it after the treadmill or bike or whatever they're on. So we do have to inject more because they do just naturally rupture. Once they do rupture, again, that perflutrin or the inert gas gets breathed out from the lungs. I did forget to mention, and it's important, that the lipid component of that is similar to the lipids of our cells. So it actually gets absorbed into the body and can be used by the body, just like the regular lipids in our body are. So they're safe in that respect. Overall, again, take-home messages is that these contrast agents are safe, even though there is some risk, just like ultrasound has some risk of interacting with the body. Things can happen. We have had black box labels and stuff that they've had to put on products like Definity in the past. When I was working as a tech, there was a time where we actually couldn't use it for a while because again, you inject something into a patient, there's a potential for things to react, okay? They used to use the lipid base, so Definity's always been the lipid based, but there's a company called Optison that now has a product that works well and has a lipid base, but they used to have a product that had an amino acid shell. Okay, the amino acids were found to interact with the human immune system. And so there'd be some immune reactions to those types of products. So, you know, those are off the market. They're no longer available. But these companies may still be around, but now they've modified their product to be in a safer type of formulation. Okay. So talking about mechanical index, so what type of mechanical index do you think we typically image at when we're in the adult heart? Just on normal 2D scanning.
0.04.
Okay, so 0.04 would be a low mechanical index. So our normal scanning is usually up around 1, maybe 1.2, something like that. So they're high mechanical indexes for our regular 2D scanning. When we do we want a low mechanical index, we have to be less than 0.4 mechanical index is what we always had to drop it down to. But now the ultra low is getting less than even like 0.2 something, okay? So they're very, very low. And again, what's the purpose of that is to prevent the rupture of those bubbles. So basically anything less than 0.4 or 0.3 would be an appropriate low-level mechanical index.
So if you were to write a true false question and you were to say, well, which one would you say so that would you use 0.3 or would you use 0.4?
So I would not give a question personally that's going to, I mean, I was taught less than 0.4. The newer standards are less than that. So I'd say definitely less than 0.3. If I was to put a question with 0.4 and 0.2, for example, 0.2 would be a better option, but 0.4 is still technically acceptable. 0.5 or higher, I'd say no. But I'm not going to give you a question that's going to split hairs on that either. I don't think that's fair. Okay, so remember the surface tension of bubbles are important. Again, the surface tension has to do with the likelihood of rupturing. So we want a lower surface tension. We do not want a high surface tension. And that's having to do with the surface tension of the bubble during that rare fractional time frame. Okay, so the earliest and most widely used FDA approved use of contrast has been the LVO, looking for regional wall motion abnormalities. That's been the longest standing in the US. Contrast for other reasons have been dabbled with in the US, but some of them still technically aren't FDA cleared for regular use. They're sort of what they call an off-label use. Meaning it's not necessarily recommended, but not evil per se.
Hey, Scott.
Okay.
Scott,
And go
should
ahead.
we be seeing your like a PowerPoint that you're going off of?
Nope.
Oh, okay. I just wanted to make sure.
I'm going between my brain and the textbook and what I got, all that
Okay,
stuff.
no worries.
My brain's full of useless facts. Okay, so I think that's really the gist of what contrasts are used for. Again, watch those the videos from the manufacturers. I think are quite helpful because they're obviously going to show you the best case scenarios and uses of it. I will say an important thing as well on the ASE documentation, as well as probably the presentation. If you're doing regional wall segments and it says that you don't have, if you can't see more than 2 segments of walls consecutively, you should be using echo enhancing agents. And so they'll probably talk about that and promote that. Again, why are we doing this? We want to do it to be able to get the best detail and the best information for the patient and to diagnose the disease as accurately as we can. So we want to use the best products we can. So the question would be, otherwise, why don't we use contrast all the time? Why do you think that might be?
Because there is a risk of, doing damage.
Yes. So even though it is safe, there is still a risk. And
Alara.
it's expensive. Okay, so we don't want to expose the patients to things that are unnecessary, but if they're diagnostically helpful, we should absolutely be using them. So my rule of thumb is, in the industry, is we probably don't use contrast as much as we should use them. And then in some labs, they will sometimes use them too much. We hired a lady in Colorado Springs that had years of experience. She worked for a company called Optison. And so she was very pro contrast agent, and she came to our lab and she used it for everything all the time. And there were situations that I had scanned with her where it actually made our case worse. So it actually didn't help where it should have helped. And you have to kind of get to know your patients and when the situation is going to be helpful versus not helpful, because you don't want to inject the patient, charge them for that, and then it turned out to make your study worse than it was. Okay, that's never a good situation. So we should probably use it more than we do, but you don't want to use it 100% of the time.
Scott,
Yeah, go ahead.
what is the decay rate of the microbubbles?
That depends on the product. So some of the products are different from each other. They're not all exactly the same, but it's very quick. So I would say that if you were to inject a bolus of it, so a bolus is an injection of one big dose that all goes in at one time, that will probably last at least 2 to 3 minutes. Okay, but likely those bubbles will rupture in that time. The other method you can do is an infusion pump, where you set it to a slow infusion. We do that actually sometimes during DEFINITY stress echoes, along with our DEFINITY infusion. It will put that in and do small dose over a longer period of time so that we sustain those bubbles longer. But the decay rate is around, they'll rupture to the point that they're not helpful within probably 2 to 3 minutes. So if you're doing a stress echo, for example, you got plenty of time to get your rest images, but it's not enough to go on the treadmill for 10 or 15 minutes and then take your post-exercise images. You need to have another dose of it by that point. Okay, so on that, you guys can still see my screen, right? So I wanted to show you some contrasts. Okay, so I'm going to put up first the LVO type of thing. So we're looking at the walls here, so you can see the walls are dark. Our gain settings and our power settings are very, very, very low. Okay, again, the white bubbles come across, they're strong reflectors, and they are powerful on that. Can you guys see that okay on the right side of my screen?
Yeah. Along that question, we want our gain really low, and we adjust it with the TGCs especially in the near field. Sometimes if we want to see the apex, we'll move the focus up. Can you please remind me how to turn down the mechanical index?
Yeah, mechanical index is always controlled by the power. So you need to find your power setting. Now, most ultrasound systems nowadays actually have a contrast preset. So you would select that preset and it's already going to have that built in for you. And it's going to be optimized for this. If you're on an old school system like the HP 5500s, like what I used when I was scanning stress echoes back in the day, we used to have to turn the power control down until our mechanical index was less than 0.4. Okay, so old school, you got to do that. Almost all new systems have settings that you just press a button or, select a preset for that.
Okay, thank you.
So you can see on this right clip here what that looks like. So a good contrast fill. Let's go. don't know what this one is.
Yeah. Scott, do you know what, as you're showing us the images, do you know what type of contrast they're using, whether it's LVO or micro bubbles or?
Yes, so these will be LVO. So if it's in the left heart and we're filling up the left ventricle, I would call that LVO because we're opacifying the blood pool of the left ventricle. If I'm doing perfusion, that's going to look a little bit different, but similar. Let me jump to a perfusion image. That's very tiny, I apologize. But this one, you can see, even though the LV is filled up, you can see an absence of filling up at the apex of that tiny little image there, sorry. See if I can
And
jump
so
in it.
that would not be considered replenishment if there were absence of filling.
Correct, yes. So it is jumping me into the article, I think. I'm hoping that the picture is bigger on here, but I'm trying to jump to it. There's some, so there's 2D without, and then you can see the filled ventricle there. Most often we're doing it for wall motion abnormalities. We're not necessarily looking for perfusion. There's not a ton of labs that do it for perfusion. Maybe if you're in a teaching facility. This one here is going to show like masses. So this article goes through different uses of that. And I think it's probably, I'm not sure who published this article.
Can we talk about something on the article that they also discussed in the PowerPoint? Or
Yeah, go ahead.
there was a contradiction about LVO being used with patients with PFO, but there were they needed some clarification with it, and I kind of got lost.
Yeah. Sorry, just type it in something else there. While we're talking about that, I'm just Googling saline. So when they had that black box warning where they actually had to put a black box label on the product indicating that there's a safety risk. At the time when I was scanning, that came out from the FDA, and there were they had defined it and said, you know, it's not appropriate use to use it for shunting. Okay, that LVO type of that Definity or Lumason, it's not appropriate to use those for shunting. Okay, and I guess the question is back then there's a lot of questions in the air about, you know, is that an inappropriate use of it? Is it appropriate use? The reality is, if I'm looking for shunting, I need a good contrast between one chamber and the other. So and shunting is usually a left to right heart type of thing. And so really what I need to see is one chamber that is free of contrast and the other one that's filled with contrast. If I've got two chambers that are filled with contrast, it's honestly not going to be helpful. Okay, because the contrast is in both chambers and I can't really see the shunt going in between it. So I would say from a physiologic standpoint, it's not helpful. There was a phase of time where they said not to use it for shunting, but I don't think it's a contraindication necessarily currently to use it for if there's a shunt there. I wouldn't say that that's a reason to not do the study. And ultimately, if that becomes a question in your lab, you're going to check with your cardiologist, and it depends on their comfort level.
So, but immediately you would know right away if you had shunting after using LVO. No,
you wouldn't, because it's going to fill up. You're not necessarily going to see where the shunt is, and you can't reliably use that as a way to diagnose it because the chambers both fill up so quickly. You can't really tell that that's because of the shunt. So there's
okay.
So there's better ways to do that is what I'm suggesting. So if I'm looking for shunting, we should be doing agitated saline instead. And often if they do a transesophageal, they will often do agitated saline with that because while they're there, the TEE is much, much better at seeing particularly the interatrial septal wall and seeing where the hole is coming across. So you'll often do it with TEE, even if that's not something they're routinely looking at.
If your purposes were originally to quantify ejection fraction or assess regional wall motion abnormalities, can you still do that if you had not known there was a PFO?
Yeah, you can. Yeah, so again, it's going to depend on your lab and their comfort level, but I don't believe that currently that's a contraindication. So if they, in other words, if they have a shunt, you don't have to not use contrast because of it. But you might, for your lab, you might have a policy in your lab and you might need to check with a cardiologist first. But you know, it's not bad if they do it per se. Okay, so let me first show you, so that you can see the syringes here with the agitated saline. So this is how we set it up. So we've got 2 regular syringes. One has some saline in it with a little bit of air. And there's a stopcock 3-way valve here that basically opens the hole between the 2 syringes so that when I'm going back and forth, I just push my thumbs back and forth opposite of each other, and that agitates the saline, okay? Then when we're ready to inject it into the patient, this other end will be hooked up to an IV tube, and then we just open it to the one that's full, and then we inject it in, you know, we slowly inject it into the patient. You don't push it really quick, you push it fairly slow but methodically until the syringe is empty. Okay, and that will go through the system within seconds to the right heart, and then you'll be imaging it. And when you're imaging it on the heart, you want to give about 6 to 10 beats at least on your clip to be able to see if that shunting goes across. Because you may not visualize the actual shunt because it can be a very tiny hole, and it may not be within that slice that you're looking at it from. But you will see bubbles that come across to the left heart. And if you see bubbles, there is a shunt somewhere. It's just determining where that is.
How many beats did you say?
I usually increase my clips to about 6 to 10 beats at least, or at least about 10 seconds is what you want your clips to be at. You do not want it on a 1 or 2 beats because then you'll miss it. And you don't want to miss those sorts of things. Okay, let me see if I can find a clip. Okay, let's try this. Okay, I know that's super tiny. Can you guys see that on the side? Okay, so you see at first, there's no bubbles in the left heart. The right is filled with them, and then after a couple of beats, you see them come in, and then all of a sudden it washes out. Okay, that definitely has a shunt. So if there's only 2 or 3 little bubbles that come across, there is a shunt somewhere, but it's tiny. If the left ventricle fills up very quickly, that means you got a big shunt.
Can you zoom in on that one more time?
Yeah, see if I can. I don't know if this one will let me. Let's see if I can find a bigger one. Actually, I'm going to jump to the YouTube here. Oh, it did. Okay, hold on. Again, I know that's not super big.
On my iPad, I can zoom it,
Oh, nice.
but I don't know if anybody else is on the iPad.
We can
That's
zoom in.
better.
Let me jump to the YouTube video. So this is a long video. I mean, I just Googled them this morning. There's tons and tons and tons. So I just Googled or YouTube searched echo contrast right to left. And so that's what came up with this video that's talking about right to left shunts. This particular video, there's a whole long, it's 37 minutes long, but I wanted to just kind of show you a couple of clips out of it where it shows it. So this is just showing with agitated saline, the shunting going across the PFO. Is that cool? Little puff. Let me go back again.
I mean, if I were familiar with TEE's views, that
Right.
would be more cool for me.
Okay, let me see. Just watch it as it goes through and you'll see it go from the right to the left. This should be playing here. Maybe I went back too far. Let's go to here. So there's a color Doppler of it. So they're showing you where it is in color going across. And then watch that poof. Did you see that? It's like a little puff that goes out into it. So I don't know that I could find a, let's see, hold on. So I just want to show a couple things on this clip. So as we go in here, so the right side is full of contrast. You can see that. And I see some bubbles here randomly in the left side. This is TEE. So we're coming up to the left atria first, the left ventricles below that, right ventricles over here, right atria is up there. But we see that puff of stuff come in. So you can easily see when contrast comes into a black space, okay? So that means that at that moment, there's more pressure on the right side pushing into the left side. And they're probably doing a Valsalva maneuver at that moment to increase that pressure. Normally speaking, the left side has a higher pressure and the right side has a lower pressure. So we often actually have a left to right shunt predominant, and then we only see that switch over when we have them do that Valsalva technique. So what I want you to notice along the septum here is that there's a black space underneath that. Okay, so if it's a higher pressure on the left and I've got fluid that doesn't have bubbles going into the pocket of fluid that has bubbles, I'm going to have a little absence of flow within that that's fresh coming into the saline. Think of that as a just like a river coming down into the ocean. You get that area of fresh water that invaginates into the area of salt water. Okay. So if left is pushing in, I'm going to get the absence of flow in the bubbles where that water is coming in, or that blood is coming in that doesn't have bubbles. Okay. I don't know if that's clear or not.
Can I ask you a question, Scott?
Yeah, go ahead.
Is the EKG funky because of the saline injected?
No, that's strictly the heart contracting. So they might have a PAC or something like that. It looks like there is at least a PAC on there.
Okay, thank you.
So the saline, the contrast should not affect the EKG.
Okay.
All right, so I'm just gonna go along here, see if they see any other spots. Here's one. So you can see that pushing through occasionally. Again, that's a transesophageal. Jump up to here. So there's several different shunting situations here. Again, you can Google all kinds of these videos. There's tons and tons of them. And I guess you can get a VRBO. So anyway, yeah, so go back and watch those video clips that I had put on the announcements. Those will be quite helpful. That's again a marketing video from Definity. So I believe that was from Definity. But it's good to go watch their videos. They'll show you where it's helpful. Again, we can see masses and tumors and thrombus and stuff within those blood pools, or we can see wall segments that aren't working properly. We can look for perfusion, and then the agitated saline, we can determine and look for shunts that are between the right and left heart. And again, for that, you really need to see a contrast difference between the left and the right heart, which is what agitated saline provides us.
Scott,
So, it's a good product. Yeah, go ahead, Kathleen.
are the video clips on a different announcement than the one that you were just showing? That was just up on your screen?
The one I was showing up on my screen, I just generically on YouTube just Googled it.
No, I mean, you had an announcement up on your screen, the announcement.
This one?
Yeah. Are the video clips on a different announcement?
No, that should be it right there.
Oh, I thought that was the lecture of that guy.
No, that's different. This is the one I want you to watch.
Okay.
Yeah,
And-
Nancy?
On that ASE upload contrast sonography PDF, they have links to videos.
Yeah.
So how do I get to that video?
So if it's in PDF form, you should be able to just link it directly.
Yeah, I wanted to see video 10, which is at the top of a page. Of one of those pages, there's a picture, maybe page 6, maybe.
Okay. I'll scroll through here and see. If it doesn't,
You're on page 4.
jump to this.
There you
one?
go. Yeah, see at the bottom of that figure, it says, wait, crumb, that's not the right one.
Video 6.
Yeah, but I think it might be the next page then. Oh, I can't scroll on your screen.
Darn it.
But it's at the top of a page like that, and it says video 10 underneath one of the pictures at the top of a page.
Okay, let me just jump through here real quick. I'm just jumping to the ones that have pictures. Here's video 10.
There, yeah,
Okay, so
see, and I click on
that-
video 10. I don't see how to get to that, but I can go to onlinejace.com, but I don't know how to see video 10 at online Jace.
Yeah, I'm not sure because it's got it in blue like that. So you'd think you can. Mine does not do that either. It only goes on the link on that. So I could click on the online jace.com. So this is the online journal. I don't know if you have to be an ASE member to access it.
Kind of look that way, but I don't know.
You might need to be.
But it's like, how do you Google video 10 from that dot? Like, it seems a little weird. How do you search for that video on that page?
That's a good question. I am honestly not sure because I don't see that same article. It doesn't pop up to right where you think it would. It just gives me the list of articles.
Yeah, that's what I encountered.
Okay, so yeah, I'm not sure I mean, if you have the access to it and you could go directly into it with membership, you might be able to. I'm not currently logged into ASE, so maybe that's just because I'm not logged in currently. I'm going to CASE, which is their online journal of case studies. See if it'll let me do this. And it's just really slow because I'm trying to download stuff and upload at the same time.
Hey, Scott, so it is recommended or it is required by IAC that all laboratory have instruments to make sure that they have systems to
So you're cutting out. So it's required or recommended that all labs have contrast
have,
able systems?
have an ultrasound machine to enable optimization of ultrasound enhancing contrast agents.
They can certainly recommend it. I don't think they can require it, but even the old systems, technically you can modify to make them work with it. So even our old 5500s don't have settings for that, but I can go manipulate it by decreasing my power output to optimize for contrast. Yeah, it'd be difficult for them to require it, absolutely, because they don't give lab accreditation or anything like that. So it'd be very difficult. Yeah, okay. Anyway, I don't think I'm going to be able to get onto this right at the moment. I can kind of explore that, but certainly feel free to, I think what's helpful if you go into Google, you can do just Google like echo, I would probably put contrast because echo enhancing agents doesn't come up with a lot of options. And then, you could do for shunts, you could do it for LVO, whatever you want, just those terminology. And I'd put GIFs. So look for the little GIF files because they're just video clips instead of watching whole, half an hour to, an hour YouTube videos. You can just watch little video clips of those. And seeing them is really where it's at. So that's what I'd recommend doing. So go ahead and watch the one on the announcement. That's the one I want you to watch. The ASE document's just there as a guide. You don't have to look through it per se. I think we covered pretty decently what these contrast agents are. The book goes over a little bit more detail about how it all works. I just want to get the take-home messages for our purposes. So if you want to read through that chapter thoroughly, it's good. But I think we covered everything we need to. Good. So the 136 class, do you guys want to meet on Wednesday? Because right now we can give you that time to put your projects together. You can email me or talk to me about, how you want to set that up. We just need to make sure before you present that our class that are on Zoom and stuff, you know how to get through and to navigate what you need to navigate. But beyond that, you guys are open to formatting and stuff to do it the way that you see fit. So we don't technically need to meet until we have those presentation days that the schedule lays out. Kelsey?
This is not about your question, so I'll let other people respond to your question first.
Yeah, Nancy?
I just wanted clarification about how long that class goes on Wednesdays when we do meet.
So
Is
it's
it done at 1 or is it done
hour-
at 2 or is it done when we're done?
I believe it's an hour and a half is what we have scheduled, but it's not going to take us that long.
So we're done when we're done?
Yeah, but it's pretty much probably going to be like in 45 minutes to an hour, I'm assuming, is usually about what it takes to cover one topic.
Okay, cool, thanks.
Scott, so in CTC Link, that class was listed to end at 2, but on your schedule, it says that it ends at 1:30. And
Yeah, it's
Which is it?
it's my schedule.
Okay,
The
thanks.
CTC link was not updated, I guess, to match my schedule. I just bumped it up because my students in the past didn't want to have to, because I allowed my students to eat in class and stuff and have lunch while we're doing it, and I figured we could go from one lecture right into the other and get it done.
So the max
Yeah.
time on that class is 1:30, but we may be done sooner.
Correct, yes.
Thank you.
Yeah, CTC doesn't always come out the way that it's supposed to. They do talk to us as program directors, but sometimes the message doesn't get all the way through to put in the logistics of it into the system. So following our schedule is more accurate. You good? Kelsey, you had your question.
Yes. So just go for quizzes, go off the Canvas, quiz dates.
Yep.
And it's just off, we're going off of every 2 days for the assignments.
Yeah, and so I'll give you a
chapters.
reminder too as we finish up a section, or if we want to move the test earlier or something, you know, I'll give you a heads up. But we'll pretty much probably keep it to schedule, I think, is probably our best bet. So, yeah, Nancy, go ahead.
I'm sorry to interrupt if you're gonna
You're-
go down that line.
I think you're good. Did you have any other
Yeah,
stuff about that, Kelsey? You good? Okay, go ahead, Nancy.
on the schedule, it says the next unit or whatever we're covering after contrast echo-enhancing agents is chapter 4, but
Yeah, so
the name
it
is
used
chapter
to be-
4.
The,
It's
the
different than-
prior version of Feigenbaum had a chapter especially for specialized techniques. Basically, what that is going to be is we're going to go over the different modes out of chapter 4 of because remember chapter 4 was the echocardiogram.
Yeah.
And they merged those chapters together. So it's really, we're going to talk about strain imaging a little bit more. We're going to talk about 3D 4D. We're going to talk about M mode, color Doppler, that kind of stuff. The modes of imaging per se. So just kind of, you know, touch up on that. You guys have kind of already read through it. So we're going to kind of touch on a little bit more when we discuss it. So that again is going to be kind of I hate to say a lighter content, but yeah, we'll get through that. Kelsey.
Okay,
It
so it'll
says-
be like review.
Yeah, it'll be basically review, yeah. In fact, I already looked at the PowerPoint this morning, and what I had already given you about screen imaging, that's pretty much most of what that was. I'm probably going to
Mhm.
add some more stuff by Thursday about 3D 4D because I want to kind of show you how 3D 4D works rather than just talking about it. So I'm gonna kind of I'm gonna look into that. I may add some content before then that will help you understand if you get into a lab that does some 3D 4D, kind of how you manipulate it, because that is something you're gonna want to know, I think. Yeah, Nancy.
Regarding that, we won't ever get to practice that until we get to somewhere who has it, because we can't do that, right?
Right. So here's so Siemens is coming in tomorrow They are coming in to kind of demo and show off the equipment and go over technologies and stuff on their system. So they have the Sequoia and the Bonsai that are in rooms 1 and 2. So they're going to be with us tomorrow afternoon, I believe 11 o'clock. You guys are welcome to kind of hang out with them through the day. They will actually show you some of those things. So they'll have a system that they're bringing in that has everything on it, like everything on it. So I think it would be good. We don't necessarily need to lecture. We've covered all the contrast stuff that we need to. So tomorrow I would rather have you there. Tyler's going to be kind of hanging out with them too while he can. But you're welcome to hang out with the Siemens folks as they're showing you the system. And that way too, if you have questions about how, you know, the systems operate and stuff, if you have questions about calculation packages and how to do certain things, now's your time to ask the experts. So tomorrow I would recommend coming in and kind of hanging out with the Siemens team. They can show you.
You said 11?
Yeah, let me see what her schedule was. I believe it's 11 o'clock. It was meant for all of us, sonography, vascular, and echo to take advantage of their time here. Let me.
Aren't we supposed to be covering the new content tomorrow?
We don't have any new content to cover tomorrow.
Oh, I thought according to the schedule, we were doing the
We're
special
just,
techniques.
The specialized techniques starts on Thursday.
Oh, okay, sorry.
So we're good. So we're ahead of schedule already. Isn't that great? Okay. So it looks like they're due to arrive at about 11 o'clock. So they're going to have a service guy there. They're going to have some applications people, which are the people to show off the system. And then the sales lady is Tracy. Let's see. They'll also be there Thursday. They wanted to show some cardiology stuff as well, some strain imaging, some 2D echo stuff. Yeah, so over the next couple of days, I'd recommend going and kind of hanging out with the Siemens team and getting to know those systems a little bit better, but they can also show you the brand new technologies and stuff that are available in the systems that we may not have. And even some of your labs may not have some of the stuff that they have available.
And on Thursday, they're going to be there at 11 as well.
I think they're going to be there at 8, so they'll actually be there early. And I believe they plan to be there throughout the day. And you can sort of coordinate with Tyler because he's going to be kind of their go-to person.
does any of our machines do strain?
Yes, the Sequoia, I believe, does strain. And those are the people that know how to use it. Yeah, Kelsey?
Just looking ahead in our calendar here as we're discussing things, it looks like we test out for quizzes on 2 different chapters on the same day towards the end of the quarter on June 2nd on diseases of the aorta and masses and tumors, both on June 2nd. Is that supposed to be that way?
No, it shouldn't be that way. I'll have to go check that one. Honestly, we could probably do it that if we wanted to, because those are pretty light chapters, to be honest, and we'll probably cover those sooner than we need to.
Okay,
So
whatever
I'll look
works.
at that as we go, and just remind me of that if I don't change it.
Okay, yeah.
That's just covering the leftovers at that point.
How did you see when the quizzes are?
Canvas.
Where in Canvas? Like just the quiz date?
I went to grades.
Oh, to grades. Okay, thanks.
So the calendar I'm looking at has diseases of the aorta on May 27th. And then
That's when we start to do it.
Yeah, so the schedule shows you when we begin it. The actual quiz day is the beginning of the next lecture, basically.
Okay, well, it says that we start AO on May 27th and we start masses and tumors on June 2nd. So I don't
So
know.
that's the calendar that he gives us to start the lecture days, Kathleen. The dates that I'm referring to for quiz dates are the grades section in Canvas.
Okay,
Yeah.
thank you.
And I
You're
do
welcome.
have a little discrepancy because when I'm looking at the assignment quizzes, even though they both say they're due on the 2nd, one has them due on the 1st, or one says that it's open on the 1st.
The first of,
June. It's the masses and tumors. It opens up on June 1st, and then the one after that opens up on June 2nd, but it doesn't say they're both technically due in Canvas right now, June 2nd.
yeah, I probably messed up in putting those dates. I'll have to just double check that. So there's two ways you can do it. You can look at it from the grades, or if you go to the syllabus page where it has the syllabus and the schedule, there's the dates under there. If I entered them correctly, which apparently I didn't, that course summary gives you all the dates for that as well. Kind of, and once I get that corrected, just looking at the scheduler right away. So I'll just have to go through and verify those and correct that. But typically we'll actually be able to finish early because I typically give 2 days per lecture per chapter. Some of those chapters we're not going to need 2 days.
Is it a final for this class or is it an optional final?
This is a required final, yes.
Okay, thank you.
So the midterm will be May 6th. That will be everything from week 1 up to that week. So that's just this quarter. It's not comprehensive to the prior quarters, except that some basic concepts will be expected to be known, such as the diastolic function and systolic function type of stuff, just basic things. But I don't comprehensively test out of last quarter. Okay, and the final exam will be emphasizing the content from the midterm through the end, but it will also have comprehensive content from the beginning, but it will be majority focused on the second half of the quarter. Okay, fair enough? Not fair at all? Just kidding. Testing's never fair totally.
So basically, we don't have any class tomorrow.
No, we don't. But I would highly recommend going and hanging out with the Siemens folks at 11, get to know them. It's a great opportunity for you to network as well, because you can get to know what that type of job is in that industry. But those folks are really handy to be familiar with because they also know where all the jobs are. So I recommend highly, even if you're not interested in doing that kind of a job, it's helpful to know those kinds of people.
Scott, I think I missed that. So where is it going to be? Where can I find them?
Just go to the lab and or room 216 area.
Thank you.
Yeah, they should be kind of intermingling there. Now, there might be other classes going on, but just kind of talk to them. They could even pull a system out of the room and take it to another room to do some demoing and stuff as well. I'm going to kind of leave that up to Tyler how they want to do that. But yeah, I would take advantage of their time as much as we can. They're extremely valuable resources. And if you got those frustrations that you've been having about those systems, they're the ones to ask. Put it back on them. They'll help you walk through it, and at least they'll be able to identify what your concern is, and maybe they can come up with some solutions for you. Good. All right. Well, have an enjoyable Tuesday afternoon then.
Thank you.
Thank you.
Take care, guys.
Thank you.
Bye,
Thank
Scott.
you.
Thank you.